And Nell and Jay, I am going to record today's presentation if that's okay with you. Just we usually have it available as a link after for folks that couldn't attend. But again, I'm going to turn it over to you two, and they are going to share some updates on the Maternal Naloxone project. And I have the slides up so I can advance them for you. And if I'm not moving quick enough, just say next slide and I can try to keep up with you.
Okay. So our project is the Universal Postpartum Naloxone to Prevent Postpartum Maternal Mortality project. Again, through the Perinatal Quality Collaborative for Maine and the Maine Medical Association Center for Quality Improvement. And Nell and I are the leads. And Nell will go first and talk about the concept and the rationale. Next slide.
So hopefully this will go smoothly. I've got 2 dogs barking at somebody doing some work. So if they start barking, I will let Jay take over. So we had multiple aims with this project. First of all, we want to reduce maternal mortality due to opioid overdose. And to do that through increasing community access to naloxone, while increasing the stigma associated with having naloxone by providing a naloxone containing first aid kit to everybody who has a baby at our pilot test site. So part of that process will be reducing implicit bias and discrimination in healthcare professionals and staff so that they are more open to seeing that naloxone is a life-saving medication, and that people who accept naloxone are part of the solution as opposed to being part of a problem. So really working on identifying personal implicit bias and understanding harm reduction strategies. Next slide, please. So the reason we chose this project is that even before the pandemic, maternal overdose was an important thing, but certainly it's gotten worse with the pandemic. And, the stress of having a baby can either contribute to relapse or it can initiate use of opioids. And we have a rise in drug overdose deaths in Maine and a significant amount of maternal mortality due to opioid overdose. So 18% in 2018 to 2019. In a Massachusetts study from 2020, which of course the data was collected before 2020, it showed that only half of people who had given birth who overdosed in the 12 months after giving birth had previously been identified as having an opioid use disorder. So really we wanted to do a universal approach to make sure that we could meet anyone who might need this, as well as family members or friends or neighbors. So we want to reduce discrimination. That has been part of this work, really highlighted that people, when they go in for healthcare and acknowledge substance use, feel that there's some significant level of discrimination against them. And we also want to acknowledge that while someone who is having a baby may not use medication, opioids, excuse me, other people in the household or visitors or even children in the household may inadvertently become poisoned by opioids that are in the home. Next slide. Jay?
So when we started this out, we thought it would be fairly simple. Of course, it turned out to not be simple, and it took us about a year to do the planning before we implemented the project. So, but the project consists of first staff and providers have taken a validated survey about their attitudes toward caring for people who use drugs. And what we want to do is repeat that survey in about 6 months to see if our education and work and giving naloxone has changed that at all. We developed an educational curriculum with the participation of Eric Harum as our content expert. And it's been put on the hospital net learning platform for completion by OB staff providers and the hospital OB unit nursing staff. And it basically has 3 components. There's an introduction to the project, module on implicit bias and harm reduction, and a tutorial on teaching how to give or how to teach administration of naloxone. Next slide, please. So in the project, every postpartum person will be provided a naloxone-containing first aid kit prior to hospital discharge. The nursing staff will provide education, and the first aid kit will contain instructions on how to access recovery resources, poison control magnet, naloxone use instructions, and a few supplies for newborn care, as well as the the naloxone kit containing 2 doses of nasal naloxone. So postpartum people can decline the naloxone, but the emphasis and the presentation will be on providing it, not just offering it. And we actually have someone from the recovery community on our advisory committee, and she said, if you just offer it, people will decline. If you give it, if the normative is you're going to get it, then people will accept it. It's very important that, and here's the kit, and what's in it except for the naloxone. There's a CPR face shield, naloxone laws in Maine, a poison control magnet, digital thermometer for the baby, some Band-Aids, and the Naloxone Saves Lives card. There's the number for the Healthy Community Coalition, which will then get people aligned with recovery resources in Franklin County. Next slide. So why did we pick every postpartum person? And initially we were going to write a prescription, but then we decided we would give it. It's because it's hard to predict who might need naloxone. As Nell said, that 50% of women who overdose postpartum were never identified prenatally as having opioid use. We want to increase the saturation of naloxone in the community. We want to avoid the stigmatization of people who do use drugs. And we want to decrease implicit bias and increase acceptance of all birthing people. And by just giving it to everyone, it not appearing on an MAR, not appearing on an insurance bill, we want to avoid the perceived risk of involving DHHS or involving insurance companies if the kit is accepted. So and we put some mechanisms in place to avoid mentioning naloxone in the health record or in the billing record. We want to make this as anonymous as possible. Next slide, please. Now we're going to talk about, do this slide, or did I walk on your slide already?
Just keep going.
What's that?
Just keep going.
Okay. So what we found in order to succeed, the first thing is buy-in from providers and nursing staff. They're the boots on the ground. We're asking them to do something that's outside their usual routine. Another thing, other people, the people who ask them to do things aren't the people who actually have to do things. They are. So it was very important to get buy-in from the providers and nursing staff, to get strong in-house champions. And I must say that the OB nurses, and especially the OB nurse in charge, has really stepped up with this. You have to have frequent communication with the project champions and project leadership. When we were planning this, we thought, well, okay, people will just hear about it after they deliver, but it becomes important to prepare pregnant people by the office staff at prenatal visits, so that people aren't surprised when they're suddenly offered naloxone at discharge. So it's not only the office staff, it's the providers as well, who will talk about this a couple of times during the pregnancy. And one of the reasons we picked the hospital we did is because I practiced there for 35 years. So it's easy for me to talk to the people there, to know who I'm talking to, and it's easy for them to talk to me, to provide problem solving and ongoing support and feedback. Next slide. Okay, you can go ahead now.
Okay, so we're going to collect data on this for a year. And, we really thought about what we needed to collect because obviously we're not going to be able to demonstrate a reduction in overdose deaths. That's longitudinal data. This is a single hospital, so that's not really very realistic. So we're going to capture the number of births, the number and percentage of postpartum people who accept the first aid kits and the first aid kits without naloxone. And we'll enter that data on a monthly basis. And then we'll identify the percentage of staff who complete the attitude survey and the net learning modules so that we can see what the change is and if our project and program, particularly the educational piece, is influential in changing attitudes. All the data will be identity protected and will be entered into REDCap. So we are part of NEPQUIN, and we hope. We know that NEPQUIN has interest in this project. Right now, they are only doing naloxone distribution to people with identified opioid use disorder. So this project, as far as we can tell, is the first in the country using a universal approach. And so we're really being very mindful about collecting our data and being ready to either showcase it or change the project based on what the data will show. Next slide. Okay, and so if the project's successful, we want to disseminate it out to other main hospitals. We'd like it to go statewide in terms of the birthing hospitals, starting with the smaller independent hospitals, probably because they're a little more nimble, although sometimes that can not be the case. Every hospital is different and it depends on the individuals who are there. And the demonstration project is funded in part by a discretionary grant from the Maine Health Access Foundation. And one of the things I really appreciated about that is that they required that while we were already focused on implicit bias and discrimination against people with opioid use disorder, they require that we also are attentive to discrimination for any reason. And so we did build that into our curricula to make sure that we understand that implicit bias is not simply about opioid use, that it can be about race, religion, gender identity. Golly, in small communities, it can be, and large, it can be about almost anything. So just really being accepting of the people that we provide care to and the people that we work with. We are seeking additional funding in order to have this be disseminated to other hospitals. So always looking for information and opportunities in that regard. Next slide, please.
So I actually have a couple other slides, Kayla, if you let me share my screen here.
Should be able to. I don't think it's restricted.
Okay, now let me see here. It looks like I can. So I just put a couple early results. Let's see, here we go. So this is the survey, the attitude survey that we administered on SurveyMonkey. And this first slide on the left just shows you the response over 10 days. And we kept sending out little reminders via the nursing staff. And with each little reminder, there was another little blip in response. So the healthcare professionals all did the survey. The office-based staff all did the survey, and 86% of the hospital nursing staff did the survey, which is not bad considering that it wasn't mandatory and it wasn't a condition of employment or something like that. And then the last slide I have shows the early results again of who's completed the net learning modules. And again, over 80% of the staff providers, office and a hospital did the 3 units. So again, it's I figure once you get a critical mass of learning, the learning will spread among the ones who didn't do it. 3/4 of the physicians and midwives did it. And again, in the 80s, up to the 90% of the staff. So I was pretty happy with that. And that's all I have. If these are our contacts, and certainly Kayla has them as well. Any questions? I'll give my screen back here.
So one other comment, that we will be providing monthly meetings for support during this. So we will follow up with this data to the hospital so they'll know how many people of each group has performed has done the study, done the survey, excuse me, and watch the learning modules so they can follow up and see if we can increase that over time. And also they'll be mindful of it if they have new hires. So we'll be using those meetings to share data, to hear how it's going and get feedback from them so we can do our quality improvement cycles. And also so we can gather frequently asked questions so that we can build a repository of those so that when we go disseminate it out to other hospitals, we have answers to questions that have already come up frequently. And then we'll just build on that as it moves along.
And there were a couple of speed bumps we've hit. The first is that by the Board of Nursing rules, a nurse may not dispense a medication that's going home with the patient. So the nurses cannot physically hand the naloxone kit to the postpartum person. We have it arranged now so that the provider will come in with the kit, leave the kit in the room, and then the nurse will do all the teaching. But Nell is communicating with the Board of Nursing to hopefully change that. It doesn't make sense in this day and age to have naloxone, which is a life-saving, no side effects or harm medication, can't be dispensed by nurses.
So the Board of Nursing rules are really an effort to prevent nurses from taking the position of a pharmacist in, pulling out drugs, labeling drugs, and dispensing drugs. And so rather than asking them to change that, it was an advisory opinion, we've asked for a specific opioid overdose prevention advisory opinion that will encourage nurses to have the ability to provide take-home naloxone in a variety of settings. So if we think about it, public health nursing is ideally poised. Nurses in public or private clinics would be ideally poised. School nurses might be ideally poised. Again, the nurses are in so many situations where the opportunity to provide take-home naloxone could really be significant. And this was an omission that we noted with the Board of Nursing, and I hope that they will appropriately rectify it. They're meeting about it in June and have been given documentation from other states who have similar advisory opinions so that hopefully we're not recreating the wheel and they have the information they need to move forward.
And the second little speed bump we hit is that when we started the project, there started to be some comments on the hospital Facebook page that were, shall we say, not supportive. For example, people who use drugs shouldn't get pregnant in the first place. You're encouraging pregnancy, the usual arguments. So I wrote a little letter to the editor to our local online newspaper. I sent the same thing to the hospital and they're deciding whether to put it up or not. But that seems to have died down, and some of the nursing staff at other units of the hospital have worked with their staff to give factual information instead of this. This shouldn't be done. People shouldn't have naloxone. They shouldn't use drugs. They should die if they overdose. That sort of thing that we hear.
Great.
I have a whoops.
Yeah, I was going to say, Elaine, I'm just going to open it up to questions. So go ahead.
So I have a couple questions. One, wondering to what extent you're able to or considering, because I imagine a lot of the moms at Franklin go to probably one OB practice or maybe one or two, the ability to sort of hand out questionnaire or what have you, 3 months later, whatever, when they come back in, were you given a kit, and did the naloxone get used, or sort of what happened to it? Because I think one of the big challenges, at least from the state perspective, is sort of understanding, you know, where does it go, who used it, what happens, and I'm wondering if there's any ability to do that. And second, I'm wondering if you've had any people in the process of this identify, you know, a use disorder, because I would think that would be an opportune time if they're being handed, you know, naloxone, and for whatever reason they, you know, use street Suboxone during the course of pregnancy or something like that. So is there any sort of mechanism in place to connect folks with treatment? So 2 questions, hopefully they both make sense.
Go ahead now.
So to answer the second one first, that's part of the reason why we have the community resources in the first aid kit, so that people can get connected. But in general, what we hear from the pregnancy-related substance use community is that people don't want to self-identify in the hospital because they're afraid of having the baby taken away. And so either people are already identified because they're in treatment, but if they would self-identify, if that occurs in the hospital, then the hospital staff are obligated to follow their usual procedure in terms of notification or reporting. So that didn't change hospital staff's obligation. But there's no part of the teaching or the education that is asking about current use. And that's part of why we wanted to do universal distribution, because we know there are people who will not disclose, and we don't want to have people who choose not to disclose not have access to naloxone because they choose not to disclose. You know, while we think everyone would benefit by treatment, that's not something we have control over. And so that's that was a considered decision. And I know early in our discussions, it was raised from a nursing perspective. Well, what do we do if somebody discloses? And it's like, you would do just whatever it is that your hospital says that you do when someone discloses. You know, that's not something we have control over. And the first question about the ability to, I'm going to have to leave here. I have the water district driving up. To follow up, we did not choose to address that simply because we were trying for anonymity so that people didn't have the naloxone in their medical record because of the stigma associated with it. Excuse me.
We're also putting a fair amount of work on the office staff and the providers. So we'd like to lighten their workload as much as possible. Again, these projects get conceived by those of us who have time on our hands and executed by those who don't.
And Jay,
Yeah, we've been, oh, go ahead.
I was just going to say, and Jay put in the chat that it is being provided anonymously with the permission of Maine General, who is supplying the naloxone. Because somebody, Elizabeth had asked about in the chat, just anonymously providing the naloxone.
Yes.
So sorry, Elaine, go ahead.
No, that's fine. I mean, and I totally respect and understand the anonymity piece of it. I was more thinking like some of the times we've been able to get data from patients is of course they show up at the practice for a follow-up and everybody sits in the waiting room for at least some amount of time. And, you know, a simple questionnaire that was totally de-identified, didn't say, you know, your name or anything like that. And just a question of, did you get this? And if so, you know, what happened to it, if anything? And then, you know, there'd just be a box they could stick it in. We've been able to gather some data that day. It wouldn't be perfect, but it just was an idea that I had for patients to just do it when they were sitting waiting to see somebody. But mostly just because I just so want to understand, and there's almost no ability for healthcare professionals to really provide this information, you know, in a meaningful way. So I'm trying to think about that from a systems perspective as well. But probably I'm a little outside the scope here, but just thinking of all these things as we chat. But thanks for doing this work.
Sure. It's certainly worth thinking about. Maybe if we spread this project to other hospitals, we can write that into the grant. And,
The other question I had related to something you just said, Jay, which was capacity of staff to work this into their already busy kind of timeline of working with the patient. And so I'm just curious on the workflows you've been identifying and what efficiencies you'll work, or like what's the, because I heard now you also mentioned quality improvement cycles. So is there going to be kind of some thoughts on the efficiency of the workflow, and with the idea of spreading to other hospitals, having a workflow of how to implement, and which types of staff members, you're mentioning the nursing things. Just thinking about that from a spreading perspective, sustainability perspective.
And part of our monthly call with the champions will address that. What are the roadblocks? What's the workflow like? The volume isn't that high, at least in the hospital, that they adding the discussion of naloxone to their discharge discussions so far hasn't been burdensome. But it's only been a week.
The key for this pilot is twofold. One is that there's only one OB practice. So all of the OBs and the midwife are in a single practice. So with the buy-in from that practice and them doing the preliminary work in the office setting, that is what sets it up so that the hospital nurses don't have as big a burden. And so that's where getting the feedback. And so both groups will be part of our monthly follow-up meetings, the office staff as well as the hospital staff, because that was an eye-opener for us. We were just thinking of a hospital-based project, but we had some early feedback that was like, people are going to get blindsided and they're going to not feel good about this. And so we went to the office staff, and that really has made the big difference. Is the office staff can address it, people have time to process, they know that this is just part of a universal project, and they can ask questions in advance so that they just know they're going to get the first aid kit at that point. And so it makes it much easier and it normalizes it. And that's really what we want. We don't want it to be that this is a targeted push. We want it that this is just part of a family first aid kit, that any family can have naloxone in their first aid kit and they can use it at will or give it to someone else. That's their choice at that point, just like anything else that they would have in a first aid kit, whether it's a Band-Aid or whether it's a, something like that. So an antihistamine, if you have Benadryl because somebody got stung by a bee, same kind of thing. So really trying to make it that naloxone is a first aid kit item and not, trying to avoid it as an emergency drug, even though that's its use. So yeah, I mean, nobody has a discrimination against people who carry EpiPens. So same kind of thing. It's just part of the first aid kit. So
we're on track to have
in mind though, Liz, thank you for raising the issue.
Have as many people die of overdose this year as die of COVID. And when you look at the resources devoted to COVID versus OUD and overdose prevention, it's a little unbalanced there.
Jay, this is Amy. You might have said that. What are you guys doing about the expiration on these meds and how to change them out if they're not used?
The supply we're getting doesn't expire till 2023. So we haven't really addressed that.
It's a valid question, Amy, and whether there would be the opportunity to exchange the naloxone, within 6 months of its expiration. So if it expired, in, let's just say December of this year, and somebody had it for, 12 months, whether they can exchange it for something with a longer expiration date. That is something that I'd love to get some feedback about or suggestions. This is a quality improvement project, so suggestions from anywhere are welcome and will become part of the process.
Has the MOMS program addressed that issue?
Well, sorry, I can jump back in. I'm on the street outside of Maine Medical Center, so it may be loud. I think, certainly getting people, naloxone is absolutely key, but I think hopefully we're getting it to them as early in pregnancy as we can. And I think revisiting it throughout the course of it, but certainly the postpartum period, as you've already mentioned, is high risk and we'll keep prescribing, but there's no sort of plan that I'm aware of, at least yet, to to do anything to sort of change stuff out, other than I think constant conversations with patients that they do expire, because I think sometimes people just aren't even aware of that. And, you know, trying to maybe really give another prescription, say 9 to 10 months postpartum, because the program goes till 12 months postpartum. So making sure that's even potentially like written into the workflow, make sure you refill this just to, because of the issue around expiration. So that's a good point.
Yep. Elizabeth, you were saying we send.
Yes. Sorry, I forgot I was on mute.
We have a location, our sort of temporary homeless shelter, which is at a local hotel, which started with COVID. And fortunately and unfortunately, there's a large amount of naloxone that gets used at that facility. So in our clinic, whenever one of the staff people, a patient has never offered it, if one of the staff people has almost expired naloxone, we'll just send ours down to the Hope House because we know it will get used within a week or two, sadly, but fortunately both. And then we get new naloxone from the new state supply, although the one I just got last month expires in 3 months. So I don't know, maybe our rotation isn't very good either.
And within that resource kit too, they do have the number and contact information too for the community resource, so that, you know, that could be something we work into future iterations of this. If it does go statewide, that's always a contact families could reach back out to maybe exchange out naloxone if it's getting close to expiring, or if they need more too.
There's so much information on the Options for Me webpage. I mean, I've been giving that out like everywhere I go. I'm just really hoping the state maintains that for some length of time, because that's another place you can get information about where to get naloxone, and it's, I feel like it's constantly being updated as well.
And we can keep you all posted as well as to what we hear on the update from the Board of Nursing as far as administering naloxone. I mean, obviously that impacts, like Nell said, nurses in many different settings. So we're hoping that there will be a positive kind of, you know, outcome on that, especially when you think about public health nurses already in the home. You know, it's something that we did not realize before going into the project, and now we know, and a lot of other licensure, you know, and boards have changed their advisories and even rules around that as well.
Well, it's unfortunate it wasn't added to the legal effort to make sure that EMS staff could dispense it, because that like just was addressed. And it was always really frustrating to me when I'd work with police departments. It's like, well, your law enforcement officers who don't have any medical training can dispense this, but your ones that do can't. So it just never made any sense to me whatsoever. But it's too bad that wasn't sort of worked into that, because I totally see the point, which is that you don't want nurses to become a pharmacy, but, you know, you need to make special exceptions to the rules. So it'd be sort of modeling off that.
Gordon had mentioned that, but it must have been too late by that time.
Yeah, I think that like literally just passed like last week or something. I mean, but there was an effort to deal with it over time for sure. I didn't even realize it was an issue. So it's too bad. I would have brought it to the forefront.
Neither did we until a month or so ago. And we said, and the nurse will walk in the room with the naloxone, and they said, we can't do that.
So Elizabeth, I see some of the questions in the chat. I know that this LD, what have you, was passed by some committee, and I expect it to be, I don't exactly understand all the legal aspects of it, but there was some great passage of it a week or so ago that I think has still some more of a process to go through, but they anticipate that being able to be done within the next 3 to 5 weeks is what I understood. I don't understand legislature stuff at all, so understand that I'm speaking from a basis of no knowledge, but I know it got through whatever the major process was, and they were very excited about that, and they anticipate being able to implement it, you know, very quickly, is my understanding.
Do you know the LD?
I'm just impressed that you can use Chow on your phone while you're walking down the sidewalk.
Yeah. So if it's not all the way through the process, then there is still the possibility to add RNs to that. So yeah, Jay and I will follow up on that. It's a slim possibility, but yeah, you know, if they tweak the language every once in a while, you can do something. So it's worth following up on, and at least knowing when it gets passed and will be implemented.
Does anyone know the number, the LD?
I have it in my email at home. I can send it to either you or Liz. I don't know that I have your email, but or Kayla or somebody. I can.
It's LD 1333.
There you go.
I just
can you
looked it
explain
up.
better than
I did not know that. I just looked it up.
Well, and if anybody understands, I literally asked Gordon to explain it to me because legislative stuff, like legal stuff, I don't understand at all. And he basically explained it as I think I just explained it. But it's interesting to think about, like, what are other, just even medical assistants, like I work with a lot of medical assistants, and what other groups are we not thinking of? Certainly EMS, certainly nursing, but what are other groups that should be able to do this? I mean, I work with medical assistants, and I just sort of assume they can dispense naloxone, but maybe they do it, under my license or whatever, because they're working with me. And so it's just something we should be thinking about globally from a state perspective, because I fully support it. There's no reason why our trained medical professionals should not be able to do this. And it's a hard thing to swallow when you can have folks who are untrained hand it out. It's tough. I mean, untrained outside of the medical, they have naloxone training. I should clarify that piece.
Mm-hmm.
MAs can do it under the provider's license. CNAs can't do it because they work under the nurse's license.
Yes.
An MA can do brain surgery.
Other questions or input, thoughts? I mean, it's, as we said, this is just a pilot so far with one hospital. We'll be kind of watching the numbers as we go and tracking that data, but any other suggestions are definitely helpful and something we can consider as we go through our PDSA cycles with this quality improvement effort.
I think just thinking back again on the piece about getting some data about where it goes, because I think that would also help support whatever, sorry, it's like really windy here if you can't hear me. It would also support whatever efforts there might be to expand it. Like, hey, look, this went to somebody who has a substance use disorder, or this was used. I mean, I routinely hear stories where like 6 kits of Narcan get used, and I can tell the town and I can say it was a 34-year-old man, but I don't really have anywhere to put that information. And so really being able to say, look at what this project is able to accomplish. This naloxone was used. I mean, potentially saved a life. And it's simple. I totally get what you're saying, but it sounds like you've got great buy-in from that one practice in terms of them doing the education up front. So if they could hand out one more sheet of paper with just very basic, what happened to it, and and they'd probably handwrite it. You'd have to sort of have some amount of consolidation, but whether you could use a medical student or somebody as a research project to do that, it would just, I personally would be super interested. And I think from a using your results to be able to sort of get this distributed more widely across the state or even other states, I think that would really help to support that as well, because that's the question: what happened to it, where did it go, and did it get used? And certainly that would help show positive outcomes associated with your project.
Yeah. So I think probably something where there was a excuse me, a quick link where somebody could just say, yes, it was used, and it was completely anonymous.
Yeah, or even I'm wondering too, even something around a certain date, months after at a follow-up appointment, a sheet of paper, just, did you receive a first aid kit in the hospital, and was the naloxone within that kit utilized too, for those that might not have access to anything online, because that does happen. So thinking about, since we do have that engagement from that practice, there might be something we could do as a follow-up question.
And if it got used, would you like another one? I mean, some way to sort of also, keep distributing it as well. So just thoughts, I mean, as we think about how to roll this out.
No, that's a great point. And I think we were so focused on getting it going and getting it out there that and like Jay said earlier, I think we're 1 week in right now, and 3 kits have already been distributed with the naloxone in them. So there's 3 more kits out there, which is exciting. But we're 1 week in. So now it's time to start thinking about, like you said, Elaine, that after process and what the follow-up is around that.
We'll certainly discuss it at our champions meeting.
Mm-hmm.
Yeah, I'm taking notes, so I appreciate it. And, really, I would love to see an anonymous way for people to say that they've used it so that they are more likely to say it was used and in what circumstances. So whether that's a paper that's in it with a stamped self-addressed envelope where you can just shove it in anonymously, or there's a quick link where somebody can enter it if via a device, knowing that some people don't do snail mail.
Mm-hmm.
Yeah, and what would be most cost effective, because that's,
Yep.
Money's an issue for all of this. Thanks so much for all the feedback.
Great. Anything else before we move on to updates? Okay, we'll move on to updates, but thank you, Jay and Nell, for sharing this. And probably, once we're a little further down the road, maybe towards the fall timeframe, we can have them come back and just provide an update as to how it's going and where things stand and how many kits are now in the community. So hopefully over the summer, there'll be a lot of uptake with this.
Well, thank you for having us.
Thank you. All right, so I will open it up to updates. If anybody else has updates they want to share on things happening in your department, in your community, projects that you're working on, just go ahead and unmute yourself if you have an update you would like to share.
It's a quiet but busy time. I don't really, so next month, I think Main Mom will be giving a more in-depth update. So I don't want to too much about what we're doing here at the state. But I think just to kind of prep people that we will have more communication and outreach happening over the next few months. So if you don't attend next month's Caring for Me meeting, you'll hopefully see more out there about the services that are being provided at the sites we have. There's a lot of energy and work going into communication materials and that type of development. And then we also have formed an advisory group of women in recovery at the department. It's actually at a department level, which I think is really exciting. Main Mom is kind of taking the lead on convening the group with support from Pat McKenzie from Kennebec Behavioral Health as our facilitator. And they have been tasked to support providing input into the work that's happening related to substance exposed infants, related to maternal substance use, and the design of our initiatives at the state. So that kicked off in March. I don't know if I don't think I was able to attend the April meeting. So I think that's one of a big accomplishment to just let people know that we're doing at the state. And then all the other Main Mom updates, I think, can wait until June because there's nothing, unless Elaine, you have some thoughts, but there's nothing super big that I can provide as a key update to this group.
No, I don't have any great thoughts. That was good just to give a brief update and lots of good stuff. We're excited. I think it's much needed. And there's really a lot of enthusiasm across the state to be doing this work. And so just being able to harness it. And I just met with a team of nurses this morning. We're just really excited to finally be able to serve this population in a really meaningful way. So I think it's really great that we have this opportunity to expand access.
I just wanted to add, as we from OCFS, our work with for the plan of safe care is continuing to really work to move along, and partnering with Liz has been totally helpful with the mom work. Ashley Olin is our plan of safe care nurse, and we're having almost 90% in April of infants who were born substance exposed who received the plan of safe care, which was either created in the hospital or with public health nursing, or even afterwards, Ashley has contacted them if they didn't leave the hospital with the plan or didn't accept public health nursing or main family. So we're really excited to be sure that families understand that a notification does not necessarily mean that a case will be opened. It's an opportunity for the plan to be created to offer services to the mom and identify needs. So we continue to educate families and the hospitals and primary care offices to understand about the plan of safe care. So that was started in January for our state.
The other piece, this is Amy, kind of go along with this, is that we've been working with the folks at Division of Vital Records to update the birth certificate. So back in January, if you're filling these out, you may have seen that there was an update to some of the language to say, instead of drug dependent moms, it says substance use disorder, alcohol use disorder. They could make that language change on the birth certificate worksheet more easily, but we're also working with them on a module to collect more surveillance data around substance exposed infants, but that won't be ready until probably next summer. But it's also collecting information like, did they have a plan of safe care, and some of the basic referrals, so that we can try to capture that information more centrally and then have better surveillance data moving forward. So that's in the works right now. I think that when we look at the data that the Office of Child Family Services collects, they're getting notifications, but what we know is that not all the hospitals are doing the notifications all the same way. So we're trying to get a better handle on what's actually happening from the surveillance standpoint. And both Gordon's on, but Gordon is working with Office of Child Family Services and the hospital lawyers and some of the lawyers at the state to really look at who's reporting what and try to see if we can come to more consistent approach to the reporting of different substances. And Adrian, I don't know if you have anything more to add on that, but that's an issue that is currently a struggle with the plan of safe care work and notifications, I think is.
It is in some of the hospitals. It's have said that they are not reporting infants who mom had marijuana use during her pregnancy, so they're not doing a notification. So that is actually affecting some of the hospitals. Feel that families are starting to know which hospitals do a notification, but the intent was not to do that. The intent is to help to connect families to create the plan of safe care and to make sure that families have a safe and nurturing environment for the baby, and help mom to be connected to resources. So we're hoping that the hospitals will understand that the federal mandate for the plan of safe care is for infants who are exposed to substances. So that's the meeting. Gordon is actually going to meet with the hospital systems, main med and Northern Light, to discuss sort of the sort of legal understanding of what the federal mandate says and what our state mandate says for around the plan of safe care, because there's not consistency across the major medical centers of reporting and notifications. And we're even getting, so for example, we had a report of a child where there was of an infant of neglect, concern of neglect, but the infant was, the mom used marijuana during the pregnancy, but the hospital didn't do a plan of safe care because they don't feel that marijuana should have a plan of safe care. But this was even an infant that there was concern for neglect. So just for people to understand what a benefit the plan of safe care can be is really important. So we're just continuing to educate the hospitals, and it ends up being a lot of the social workers and care managers in the hospitals So Ashley, our Plan of Safe Care nurse, has office hours monthly. She's available to do trainings. We've done trainings with all of the birthing hospitals. So it's a matter of sort of education, which we're really working hard to continue to help people to realize the value of the plan.
So MICUS, Maine Independent Clinical Information Service, has a webinar coming up in 2 weeks on Tuesday, May 25th at noon. And thank you to MMA CQI, who've been managing it and will be hosting it. Elizabeth and Charlie Padavina and an attorney named Ben Townsend will be doing an update on legal and regulatory opioid prescribing. You may recall, MICUS, during the years that we focused on opioid education, opioid prescribing education, often included presentations by Gordon or Peter Michaud from the MMA. And so we're going to do a brief recap and review of the Maine law and opportunities for Q&A. So again, 12 to 1 on Tuesday, May 25th. It'll be in the MMA weekly update. It has been, will be for the next 2 weeks. And you can contact me or Kayla if you have questions.
And I put the link in the chat for registration, but if you want like the full program announcement to share or anything like that, just let me know. It is going out, I believe, in the Caring for Me follow-up email, but if you want it sooner, just let me know and I can get it out that way too.
I will follow up. Oh, go ahead, Sue.
I was just going to say, and MICUS is continuing to offer the one-on-one sessions, the academic detailing sessions on opioid prescribing. And we will continue to do that. Our new program year is going to start in July. So we'll be speaking with our contacts at the state, at the Office of Maine Care Services. That's where our contract's from. So we'll be meeting with them in the next few weeks to talk about our next year's plan. We will be launching a non-opioid related module that'll start next month. But we do intend to continue to do the opioid prescribing one-on-one sessions. So we'll hopefully have more to tell you about that in the next month or so. Sorry, Elizabeth, go ahead.
No, I was going to follow up on two of those things. One, our non-opioid module is Hep C, which is incredibly intertwined with opioid use disorder because over 50% of people who use drugs, people who inject drugs, are suspected to be Hep C positive. So we're rolling that out. We're going to have different hours, a group class and an individual class for providers, especially people who work in addiction and treatment services, to be able to treat Hep C. And we developed this at the request of DHHS. I don't know if it was Dr. Jensen's influence or some other initiative on the part of the state to get more Hep C treatment. So it's going to be really exciting. And we're launching it at Amanda Richards, who is on, at the MOA, which is sold out live. And I had the great problem yesterday of thinking, oh my gosh, so I give a talk in a room with people not using the Zoom polling feature because they'll actually be there with me. So it was a great dilemma to have. And the other thing to follow up on our one-on-one academic detailing, we had a request last week from a pediatrician who is required by law to have 3 hours of opioid education. And she's a pediatrician and she's an MD and she doesn't prescribe opioids. So I was really stretching, like trying to make this one-on-one class pertinent to her. And we talked a lot about drug-exposed infants. We talked about the Plan of Safe Care. This pediatrician had never heard of the Plan of Safe Care. And so I was able to pull that up pretty quickly in the Maine Mom program and go through a lot of that information so I could make her opioid education relevant to the patients that she's actually seeing in the office. So it's been really helpful to be a part of this group, to know about those types of programs from Adrian, from Amy, to make sure that we can, get providers pertinent education.
That's great.
Can I just ask a clarifying question? I just want to make sure that the MICUS work with the opioid prescribing includes like buprenorphine, right? Because we have some folks that with the Maine Mom team that are really needing kind of probably, I would say, a higher level of support than we can provide sometimes, with more of the sort of standard questions around Suboxone prescribing, getting a clinic up and running with just doing sort of that type of work. Can we refer them to you? I just want to clarify that piece of it.
So I think I have two answers to that, Elaine. One is that MICUS does have a 1-hour MAT intensive, and so we do a needs assessment with the learner, and we try to help direct them to evidence-based prescribing references or buprenorphine prescribing. So that would work for some people. And then the other option, which I'm sure Kayla might want to talk about, is the Support for Me, which is, I feel like, this sister program to Maine Mom, because we've modeled a lot of it around what's working really well in Maine Mom in terms of office hours on the second and fourth Friday morning, and a Project Echo. And we also have that technical support. So it's not just prescribing buprenorphine, but it's some of the workflow stuff. So I think in MICUS, we focus more on the prescribing aspects. And then with Support for Me, we have a little bit more ability with Karam to talk about workflows and drug screens and interpretation and those types of things. So I think between the many programs that are going right now, we have a lot of opportunities for people to customize education.
And Elaine, if it's easier to give out like one email, you can always give out mine, and then I can, pass over to Sue and Elizabeth for MICUS versus Support for Me as well.
Yeah, I may have just like given the site to MMA where the MICUS information is, but that's really good to know, Kayla, from a connection standpoint with Support for Me. That's really good to know.
Yeah, we can get it passed around. Great, so we are a little bit over, so I don't want to hold people up too long. Thank you everyone for joining. And as Liz has mentioned, next month we'll have a more in-depth update on the Maine Moms program. So we're looking forward to that. And I hope everyone enjoys the rest of your day. Thank you, everyone.
Thank you.